All right, since Bernie scheduled everything so tightly, I think we really actually have to get going, even though I know that people are still clearing out from the last talk. So this session, in case you're wondering what session you're in, is called Spinal Cord Injury and Neurologic Disorders, Clinical Pathways. And the order of the speakers will be, I'm Evan Snyder, and I'll talk about spinal cord injury. Then Tony Windebank will talk about ALS, and then Xianmin will talk about Parkinson's disease. I think the one thing, and I'm going to let them obviously give their own talk, what we'll do is we'll take all the talks together, and then with the time left over, we'll have a panel discussion here where we can take questions. And the reason I'm doing that is that I think you're going to see common themes. Even though these are different diseases, you're going to see that there's common themes that I think that run through them all. And I'll kind of lay the groundwork, but I guarantee what I say is not going to be the last time you hear these concepts, maybe even the same words. So I'm going to be talking about the challenge of spinal cord injury to the stem cell field. I'll give a little bit of a quick introduction, Chairman's prerogative, of talking a little bit about my particular view of stem cells. And I think everybody's here because they recognize that the understanding that there is a stem cell was paradigm shifting, not just for the nervous system, but for the entire body, even though as a neuroscience chauvinist, I'm going to claim that it was the nervous system that gave rise to regenerative medicine. The reason being that our organ, the nervous system, as opposed to the blood, the skin, the gut, the liver, was thought to be absolutely rigid, non-plastic, to have this kind of very deterministic construction that lasted all throughout life. When it was recognized that there were cells that could do this, all of a sudden the possibility that there was actually plasticity in what was thought to be a non-plastic organ hit consciousness, was on the radar screen, which then meant regeneration and gave rise to regenerative medicine, and then all the other organs like the heart and started saying, oh, I wonder if we can do what those brain guys are doing. That's my view, quick historical view of the advent of regenerative medicine. But I think it's important to recognize that even though all of us are imbued with enthusiasm for stem cells, to understand them and to use them effectively, I think we have to recognize these are still fundamentally part of developmental biology. They're part of intrinsic developmental programs. Stem cells were there to participate in organogenesis and then to maintain homeostasis all throughout life. So these are their biologic imperatives. And if you go against those biologic imperatives, nature will always win, and that's the obstacle. So the biggest obstacle to therapy in regenerative medicine has nothing to do with funding or regulation or investors or things like that. It's still the biology. So no matter how you get to become, and I'm going to use neural stem cells as an example in the nervous system, no matter what route you get to be a neural stem cell, whether it's from the fetus, the adult, ES cells, IPS cells, we all focus on what is this cell doing. And what the imperative of this cell to do is to put the system together and then maintain it. So it's not just neurons, it's also oligodendrocytes, and then an underappreciated member of the niche, the astrocyte. It's also important to recognize that when you do a transplant with a cell into a pathologic host, it's a dynamic. Both elements change. The stem cell changes, the host changes in response to these various arrows that have to be understood. Now, the host does instruct the stem cell. Naively, we used to think that we didn't need to know anything. You know, that the stem cell spoke to the abnormal environment, and in the midst of our ignorance, we still got what we wanted. And I'll take the blame for having planted that seed back in the early 90s when Jeff Mackless and I found that in the adult, if you created an apoptotic, an isolated artificial apoptotic environment in the adult cortex, and you put undifferentiated neural stem cells in there, you got pyramidal neurons, some of which send projections across to the other side. Though outside of that apoptotic area, you got what you would expect, just glial cells. Well, it was a cool finding, and it wasn't wrong, it was just artificial. Most real diseases are not single processes or single cell types, and they have, a whole tempo. So it was misleading to do that. But when we start approaching real diseases, and spinal cord injury is a poster child for this, there are many, many things going on. As you'll find in the other diseases that you're going to hear about today. So with spinal cord injury, and I won't read this to you, there are huge numbers of pathologic processes going on. There's edema, there's release of free radicals, there's swelling, there's tissue dying, there's scarring, there's all kinds of processes. And targeting any one of these individually will not work. We have to target all of them. Now, fortunately, as we're starting to become more sophisticated in what we think the actions of the stem cell are, we're starting to realize that many of these actions, if they're used appropriately and used cleverly, can map to many of these. So this was a lesson, following on the stuff that Jeff Macklis and I did. We learned this lesson the hard way when Ted Tang was a postdoc in the lab. And we hooked up with Bob Langer, and Bob came to me and he said, let's make Superman walk, because Christopher Reeve was alive at that time. And we're going to take this really bad injury, a huge hemi-resection across a few sections. We're going to take stem cells, we're going to put it on a scaffold to give it some substrate, bridge the gap, and voila, the animals were going to walk. But let me show you what the data actually were. So this is an animal without intervention, huge hemi-resection. And you can see, even though it's a hemi-resection, it's large enough where you really get very poor ambulation. Both hindquarters are severely affected. There's poor weight support, there's poor movement of the lower of the digits, no coordination. And on the BBB, 21-point BBB scale, this guy would only get maybe about a 3. Next, you're going to see an animal who received the stem cells supported by this biodegradable scaffold. The scaffold is kind of like what dissolvable sutures are made of. The animal is not normal by any means, but somewhat better, as you'll be able to see. So now there's better coordination, better weight support, movement of the digits, and on the same 21-point scale, the animal would maybe get about a 14. So we're completely excited, just have to do the histology. So we start staining. Here's the epicenter of the injury. We can see neurofilament fibers coursing through the epicenter, and we're just getting really excited now. We're thinking, stem cells are the greatest thing since canned beer, and we should be booking a plane to Stockholm. All we needed to do was now show that these guys were ours. In other words, they came from the stem cell, in which case they should double stain for a red marker for the stem cells. Well, here's what we found. The cells were there, but they ain't the ones giving rise to these fibers. These fibers all came from the host and cells. So now Ted's thinking, oh, now what? Well, we realized that that's not what we expected, but it gave rise to what I call the Rolling Stone rule of stem cell biology. You don't always get what you want, but sometimes you find you get what you need. And what was happening was that in this area that normally should have this great degree of scarring, that's what the green is, the scarring is absent, and instead what's going through, kind of poor, but it's making it through there, are fibers going through formerly a no man's land, both sensory and motor fibers. And the cells themselves, those are the red ones, these are human cells, were making factors that were inviting in host cells that would go across and start kind of pushing their way through the epicenter. What was also happening is it was preventing, here's a syrinx that you would see, that the presence of the cells, particularly when supported in this way, eliminated the syrinx. And then what we also found was tiny little extension cords. So they were becoming neurons, not these long projection neurons, but tiny little extension cords. So if here's where the implant was, if you put a track tracer down here, if it's really sending down a fiber, then the blue dye here should go up to the cell body. And that's exactly what you see. These are the cells, and this is blue because it sent a process down here. And there were even some fibers going up into the brainstem, into upper centers. So here in this case, you put a green dye, and the cells, if they're sending projections up there, they should be green. Or as I showed you before, if you put in a blue dye, they should be blue. So in total, this combination of these various actions was allowing there to be better, higher control of lower functions. And that's indicated here by looking at cortical evoked potentials. So here's motor evoked potentials, and here's sensory. Now, here's what you would see with no treatment at all. And here's normal. So these guys aren't normal, but they're certainly better than this. It means that there's some upper center activity making through there sufficient that if you take all this together, that they now are starting to achieve a function. And this, the BBB scale is not linear. They go from not being weight supporting and ambulating to now being able to do some degree of weight support and coordinated ambulation, as recognized here. And of course, there's spontaneous recovery, so anybody who does spinal cord injury always has to take that into account. So how does the stem cell have this division of labor? Well, that's these other arrows. The cells talk to each other. There's a division of labor. Some may become neurons, but a lot of them, depending on the cues in the environment, become non-neurons. But these are critical. And replacement of that is critical. So feeding back onto the host with neuroprotective molecules, anti-inflammatory molecules, anti-scarring molecules, mobilizing endogenous precursors and progenitor cells that send out neurites, and even invite vascularization by host angiogenic clusters. And they do this by diffusible factors, by cell-cell contact through gap junctions, these pores that allow very tiny molecules to go from one cell to the other, and even through emitting exosomes, these kind of little bubblings off of stem cells. Taken together, all of these mechanisms gave rise to what we dubbed many years ago now the chaperone effect. And in fact, it has played itself out through many aspects of the nervous system. Collaborating with Gene Redman and Dustin Wakeman, who actually is receiving an award for a lot of this work, we found that the stem cells in Parkinson's disease did have a real impact, because they preserved the nigrostriatal pathway. So the chaperone effect in neurologic disease has played itself out in many disease systems and in fact in many organ systems. The heart guys, that's when they see improvement in cardiac function, it's the chaperone effect. So the next thing, of course, was to see whether this could be extended to start moving into clinical trials. We would need to do large animal models, and now we're starting to work with the company that Bob Langer founded around the work that we've done called Invivo Therapeutics. And these are monkeys in St. Kitts, Gene Redman's monkey colony, and doing the exact same thing. Now, stem cells on these biodegradable scaffolds into thoracic injured animals. That's what you can see over here. And where they were on the hemi-resection in these animals, there was a diminution, less silver, meaning less degeneration, less of this brown, meaning less inflammation over here. So that was, again, evidence of the chaperone effect. And we've, and behaviorally, as you can see over here, what one is able to do is actually to image the hindquarters of the monkey and kind of get a picture of their stride length. So an injured animal has a restricted stride length, one that receives stem cells, and this particular animal is not a neural stem cell, it's another kind of stem cell. You can see that now the stride length here is certainly bigger than this. You can see a wider excursion and more normal over here. Interestingly, the scaffold can do the same kind of thing, not as well. There's a synergy between the stem cell and the scaffold that we'll talk about a little bit later. But this is really kind of interesting. And in fact, now the scaffold alone is in clinical trials The next phase is we're going to start adding cells, neural stem cells, to it, and try to get that through the FDA as well. Now, the field's biggest challenge still to this day, oops, man, sorry about that. Oh, okay. There's an announcement keeps coming up on my computer that I have a meeting, and I want to try to get rid of it because I can't do it, but I keep on screwing up the computer. So the biggest challenge in all of neurologic disease, and particularly spinal cord injury, is the fact that everything that I've showed you has been with acute or subacute injury. And that's not just our lab, that's the entire field, and it's across organ systems as well. But that's not the patients that come to us. Most of the people that come to us have been in wheelchairs for years. That's stroke, spinal cord injury, it's neurodegeneration, but at end stage. So this has been regenerative medicine's third rail. So this is what we've tried to embrace, and this is in fact what the field needs to try to embrace. So one approach, of course, is to try to fool the system and the cell into thinking that it's been recently injured. So try to recreate the subacute or acute milieu in the chronic microenvironment. So characterizing what happens acutely, molecularly, in this acute area, but then just using those same molecules out here. And I won't go through the data that indicates that, but it's the normal players that you would expect. Arm the stem cell, maybe even arm the scaffold to express some of those. And for example, NT3 is everybody's favorite, and that really is upregulated after the acute injury. So engineer the stem cell to make NT3 that will spill it out, it'll work back onto the cell and then onto the host as well. And in fact, in an ischemic environment, we can do that. These yellow-orange cells are now extensively more neurons, as you can see, maybe 80% neurons that have all the right neurotransmitters and even making an impact on host cells. So that seems to work. You can put in spinal cord, you can get the stem cells to make GDNF, and if you do that, if they overexpress GDNF, they naturally make GDNF, and I'll come to that point, but you can get them to overexpress GDNF, you can get even more fibers. But the lesson that also needs to be learned, I think, is this that Mark Chizinski and I found is sometimes you can't fool Mother Nature, and that gets back to one of the points I was trying to make. So we would do kind of a dorsal funiculotomy over here, and the neural stem cells caused motor neurites, neural fibers, to course through there, which is great, chat-positive fibers. When we cleverly, what we thought was cleverly, got the neural stem cells to overexpress NT3, they actually got less motor fibers going through, as you can see over here. But we did get more neural fibers. The only problem was that they were sensory, which is not what you want. So in fact, what you saw playing around with this, you actually get this effect, that increasing one actually changes the dynamic within the cell so that we got less of the other. In making them more neurons meant that we got less of GDNF, which is what we didn't want. So we have to know the biology. But it's going to take more also than just doing what we did with acute and subacute injury in the chronic injury, but just doing higher dose, longer, more of it. We need whole new paradigms, I think, because things completely change in the chronic environment. There's atrophy, there's encephaloceles, there's vascular redistribution, there's neural redistribution, there's cortical regions taking over for other regions, there's even intraspinal regions taking over for other regions. So we need alternative routes to the muscle, and this is going to take combined approaches, which drives regulatory people and manufacturing people and biotech injury nuts, but that's probably what we need to do. So what we're doing is taking the approach that seemed to work in the subacute environment, taking the scaffolds with the cells, and recognizing that the two together are quite synergistic, that they attack many of the aspects that you see in this paradigm shift in the chronic injury, but playing with it, playing with the scaffold, playing with the cells. Ted is spearheading that, and now in chronic injury, these cells now overexpressing NT3 If you take an animal that's plateaued now in its recovery, so now it becomes chronic, but doesn't really completely get better, but now you do an intervention. You put in the implant with the stem cell on the scaffold. Now you make it through and you get him to improve even better. And now he has weight gain, he has weight support, and you can start seeing fibers making their way around. We also saw something very interesting. Getting back again, sending down neurites, but in this particular case, what seems to happen is that they engage intraspinal motor programs. These are the programs that let a newborn baby do stepping, and then they disappear because they are superseded by higher centers. But they don't disappear, you can re-engage them, and it looks like this kind of mechanism, the cells with the scaffold, now re-engage these, so an alternative route to the muscles. And you have to remember that you don't need to get your animal or even your patient to run the Boston Marathon. You just need to acquire another 1 to 2 segments of function, and that's a major impact. Now somebody can breathe, or can have bowel and bladder control, or can move their thumbs. That can be life-changing. Other aspects that we can play with are the fact that the host talks to the neural stem cell and draws the cells in various directions. We call it pathotropism. We saw it in many areas. It was most prominent. We saw, we published this going, arming these cells to attack tumors when Karen Aboudi was a postdoc in the lab. Well, it turns out that one of the drivers is inflammatory cytokines. And the prototype of that is STF1 alpha and CXCR4. And it plays itself out in all of these. Now, this mechanism happens acutely. Also, you don't want to put inflammatory chemokines in there, but you may want to have control of it. You may want to detoxify the inflammatory cytokine so that now it's not signaling anymore, the nasty signaling, but you maximize binding and you minimize signaling, and now you have a peptide, so you can now direct the cells to go where you want them to go. And just looking at trying to get cells to do this in one of these neurodegenerative diseases, Jean-Pierre Lee was able to now make the cells have just a restricted movement to now completely cover the brain and result in better improvement or slower, longer lifespan and better motor function. So another approach for chronic injury is also changing the host niche. So I'm going to end here by saying that injury to the spinal cord is characterized by many different kinds of pathology. Now, fortunately, and I won't read it to you because I think you can see it here, is that many of these aspects of pathology map to many of the actions of the stem cell. So cell replacement, but recognizing that cell replacement is not just neurons. It's the astrocytes, it's the oligodendrocytes, trophic support, decreasing inflammation, decreasing secondary injury, scavenging free radicals, inhibiting scarring, causing angiogenesis. So even if this is what your goal is, I'm going to make the argument that the only way you can effectively do this is still to be a translational developmental biologist. Understand the developmental biology and then figure out how to harness it. Again, understand the multiple actions of the stem cell, and understand the multiple actions that are going on pathophysiologically, and see to the extent that you can get them to map in multimodal approaches. So with that, I'm going to turn it over to Tony, who's going to talk about ALS.
Okay, we're ready to go. Thanks very much, Evan. That was a great talk, and I think a really great introduction, and also Evan has been a really major player in the field since the beginning of neuroregeneration, and I think that perspective really gives you the vision of how complex the field is, but as one moves through the disorders, how many common factors there are. And as he said, you'll see these common themes that will come through as we give the different talks. So I'm going to talk about a neurodegenerative disease now, amyotrophic lateral sclerosis. And this is, talk a little bit about age-related motor neuron loss and how this is accelerated in a degenerative disease. Very briefly about mechanisms, because that's a minefield. But then something about approaches to treatment and a rationale for the use of stem cells in treating ALS, and then something about the current trials that are going on. So one of the, I'll say a little bit, well, no, quite depressing things about ALS is that basically the incidence, the prevalence has not changed at all. Long term, we have monitored this in our Minnesota community going back many, many years, and the solid line on the left represents the survival from ALS between 1925 and 1989, and then the next decade there between 1990 and 1998, done it again, and it's absolutely unchanged. So the disease doesn't change with time. So if you look at the body and the brain and the nervous system, you get a gradual loss of neurons associated with aging. And these are two completely separate studies. One was an electrophysiological study on the left. The other was an actual counting neurons in the lumbar spinal cord, which both very, very similar, suggest that after about the age of 40 or 50, you start to lose about 4 to 5, maybe as much as 7 or 8% of your motor neuron pool per decade. So you lose neurons naturally, and this loss of motor neurons may be part of the association with the frailty that goes with aging. ALS is called Lou Gehrig's disease, and Lou Gehrig was known as the Iron Horse. He played more than 2,100 games consecutively without a break. In 1936, he was on the cover of Time magazine as the game's #1 batter. 1938, his batting average just started to slide a little, and I think he was 36 or 37 then, and he thought this was because he was beginning to get older. In 1939, he actually came to Mayo Clinic, and the diagnosis there was made of ALS. 1939, he gave his luckiest man alive speech at Yankee Stadium. In 1941, he died at home in New York. So if you look at this picture of him, this was taken at about the time of the luckiest man alive speech, and you can see the muscle atrophy in his hand there. If you've ever watched that movie, the original, you'll see as he walked out onto the field, he was clearly limping. It was very interesting as he put his hand up to wave, you could see the muscle atrophy, the fact that he couldn't control his fingers very well in that hand. So back to this loss of motor neurons with age. If we'd been looking at Lou Gehrig's spinal cord and motor neurons, what we would have seen is that several years, probably as long as maybe 5 or even 10 years, before the onset of the disease, he was starting to lose motor neurons. And that after 2 to 3 years of this loss of motor neurons, it started to become symptomatic. And this is characteristic of neurodegenerative diseases. We have a lot of reserve in our neuron pools, and you probably have to lose between 70 and 50, or 50 and, go backwards, between 30 and 50% of the neurons before you start to notice symptoms. And this probably goes for Parkinson's disease that we'll be hearing about, Alzheimer's disease, and certainly motor neuron disease. So it's an age-related neurodegenerative disease. It's slightly more common in men than women. It's very consistent across different races. And if you're a man, there's about a 1 in 1,000 chance, if you live into your 70s or 80s, of actually getting ALS. And part of the big advances over the last going on for 20 years now, is the identification that up to about 10% of cases are familial. I'm not going to go into that in detail, except to say that when you look at the familial cases, what's happened over this 20 years, there's now about 25 genes that have been identified that are associated with familial ALS. All of which, or many of which, have very different functions in different parts of the cell biology of the neuron, but which end up with the same phenotype of progressive loss of motor neurons. And it's the progressive loss of motor neurons that causes the weakness, the muscle atrophy, the spasticity, and Unfortunately, it affects the breathing muscles and may affect the speaking and swallowing muscles. And the majority of people with ALS, the average survival, median survival from diagnosis is 22 months, and most people die with respiratory failure. So it's a very, very dire disease. Treatment is not lacking because a lot of things haven't been tried. So this is just a list of most of the medications that have actually been put in, or drugs or biologicals that have actually been put into trials for ALS over the last 30 to 40 years. And you see that there are small molecules, there are growth factors like BDNF and CTNF and IGF-1. So a whole series of drugs that have been tried, the vast majority of them based on targeting a cellular mechanism that's known to be affected in ALS. But unfortunately, none of them have shown any benefit. The only one that's been approved is Riluzole, or Rilutec, which slows progression, perhaps in a subset of patients, and may extend life by maybe 2 months. So it's certainly not a dramatic benefit. And so why is there no effective treatment? Well, as I've alluded to a couple of times, the mechanism is clearly complex and definitely not understood. We've said many empirical trials have failed, and I'll give you a good example of this. IGF-1, which is a very potent motor neuron trophic survival factor. And this was identified back 16 years before it went into clinical trials in animal models, was very effective in treating one of the genetic animal models of ALS and a spontaneous mutant model. It got into, it was very successful in animals. It went into human phase 2 trials, and it looked like there was an effect. And we actually organized the phase 3 pivotal trial, 330 patients treated over a period of 5 years, treated over 2 years with IGF-1, and there was absolutely no difference between the treatment and the control group, so extremely disappointing. So going back again then, why don't animal models predict the therapeutic response? Well, one possibility is that the models either don't model the disease appropriately, or they don't model the human response to the therapeutics that you're trying. Another point may be that in an animal model of a disease, a genetic model of ALS in a mouse, one of the things that you get is very synchronous onset of disease. You've got a whole bunch of mice, and you know when the disease is going to begin, so you can treat them right from the beginning when those motor neurons are just starting to disappear. So it may be that we can see effects in mice, that when we put them into the more heterogeneous human population, this effect simply isn't big enough to see. Another possibility is that the therapeutic factor doesn't reach the target neurons. If we look at the nervous system on the right here, the brain and the spinal cord, it's enclosed in its own compartment within the blood-brain barrier, and most of the molecules that have been tried don't effectively, or don't very effectively, cross the blood-brain barrier and get into this CSF space that bathes the nervous system. So one of the potentials here is to use stem cells, and in this case MSCs, mesenchymal stem cells, as we'll call it a Trojan horse that you can put inside the barrier and produce things inside the barrier that may benefit the nervous system. And if we look at MSCs, there's a number of, there's some experimental data and biological data that suggests these are cells that travel to areas of injury and cell loss and promote a more supportive and healing, pro-healing environment. And we know that MSCs secrete literally dozens of cytokines, we also know, and this is a really interesting area that's developed over the last 3 or 4 years, that they are producing and budding off large numbers of extracellular vesicles that contain all sorts of molecules of interest that may affect processes in the nervous system. So what you have is a cell that from many, many different trials now we know is relatively safe, or is quite safe to give to humans, that secretes a lot of trophic factors of interest and that may be pro-survival in the nervous system. So it's a little bit about like taking, okay, for years we've tried the single approach to trying to make the cells survive. Single molecules, single biologicals, single manipulations. In a way, the MSC is a way of delivering a whole bunch of different things to the cells if you can get them into that CSF space and into the intrathecal space, where they will then continue to deliver the factors that they're producing. So that's the rationale behind using MSCs in ALS trials. Now, as we'll talk later very briefly, the second part of this, that okay, if we can establish that it's safe to get these cells in, demonstrate that they survive and that they're biologically active within this CSF space, we can also modify them to produce other factors that, we have lists and lists of candidate molecules that may be neurotrophic that we can deliver directly to the nervous system. So as we've gone into these trials that I'll describe in a moment, rather than thinking about, are we going to be able to do a trial where we have a placebo group and a treated group, and we'll see a difference between these two groups as statistically significant, and we'll get the answers quickly. We're taking a little bit of a different approach, which is to use more of an adaptive type of design, which is to say, probably not. We're probably not going to see a clear-cut response right from the beginning. So rather than just doing a standard clinical trial design, let's look at treating pools of patients with ALS, but really carefully characterizing these patients so we can derive iPS cells from their skin fibroblasts. We're going to get autologous MSCs from the patients, which we can characterize. We're genotyping all of the patients. We can have very good clinical phenotypes of the patients, and we can have other biomarkers as well. And using these then, if we treat the patients, can we then identify a pool of responders, and then in the next iteration of the clinical trials, amplify for that pool of responders, at the same time looking at what are the characteristics of the responders from the point of view of their own cells, the iPS cells that you can derive, motor neurons derived from iPS cells of the patients, and of their MSCs, so that you can hopefully the goal is to identify this subgroup of responders and then enrich for that and move on into the next phase of the trial, or phase of trials, where you take this subgroup of responders and treat them with your best type of cells. So that's the overall sort of thinking behind the trials. So where we're at with this is that using this as autologous adipose-derived cells, we did a pilot study, a one-patient, single-patient pilot in July 2010. Parenthetically and ironically, it was driven by the fact that this was actually the director of our human cell therapy lab who came to see me and said, gee, do you think ALS would ever respond to using MSCs? I said, well, it's something we've been thinking about of interest, but we haven't really moved in that direction yet. He said, well, will you speed up because I've just been diagnosed with ALS. So he was going to be our first patient, but in fact he unfortunately had very rapidly progressive disease and passed on before we were able to get approval. But we moved on using the model we developed here and started with, in 2012, with a 27-patient dose escalation study. And the basic design of the study and what we're doing here is to take the patient, and this graphic is a graphic that we use when we're visiting with patients and their families to describe what we're doing within the study. Because when you're doing clinical trials in diseases like ALS, which are uniformly rather rapidly fatal, and you start talking about stem cells, then the possibility for therapeutic misconception becomes incredibly high. So you have to really understand with the patients and their families that this is research. We don't know whether this is going to work. At the moment, we're trying to find out if it's safe. And what's really interesting is that the majority of patients go into this with very open eyes, saying, it may not help me, but if it helps the field, if it helps somebody in the future, it's worthwhile. So adipose biopsy, and then we take the cells into the cell therapy lab and isolate the plastic adherent cells and start to expand them. Now we've actually got two different studies going on at the moment. One is with autologous adipose unmodified cells. The other is with bone marrow-derived cells, which have been modified to increase their expression of neurotrophic factors, especially BDNF and GDNF. So they're two slightly separate trials that I'll elucidate. But basically, you have a trial of either normal cells or neurotrophically enhanced cells, which you can expand into large numbers. And then these are delivered to the patient by intrathecal injection. So the patients come into the clinical research unit, do a spinal tap, and insert the cells. And carefully explaining to the patients that we're not expecting these cells to become new nerve cells. We're hoping that they will enhance the survival or protect the surviving motor nerve cells. So this is the safety study of the adipose-derived cells, and these are the groups of patients. So they went through a dose escalation with 5 patients in each group, and then patients who were getting 2 doses. So they get 1 dose of cells and then a second dose a month later, and up to the highest dose. And we've got up to the highest dose, 2 doses of cells. So all of these patients have been treated, and now we're observing them. And one of the really challenging things to manage in a trial like this is that we've had, without advertising or marketing of any kind, almost 1,500 patients who've contacted us wanting to enter the trial. So if we look at these, what we're doing, this is safety studies, this is not efficacy studies, but we are studying these patients in great detail, multiple CSF examinations, multiple imaging studies after the injections, but also carrying out the standard ALS functional rating scales. The rating scale is on the right. It's a subjective symptom reporting scale. And what we've seen in this study is that the adverse events are very mild. When you get up to the highest doses of cells, then most of the patients report maybe a little bit of back pain and a little bit of discomfort in the legs that settles within 2 or 3 days. So the safety profile of the cells has been very, very good. We've had some other symptoms like headache that's been mild. 1 patient developed tinnitus, and as I said, several patients have had some mild leg pain. But a number of the patients are reporting subjective improvement. Very, very cautiously interpret this because I've been in this business for a long time, and the placebo effect, even with a disease like this, is extremely strong. But about half the patients in the highest dose group are reporting that there's something that they couldn't do before that they can now do, like peel an orange or lift a jug of milk out of the fridge. So, as I'll say at the end, there's enough of a signal there to say we should move on into phase 2 studies. One of the most interesting things that we've seen is that in the higher doses of patients, patients receiving higher doses, this is an MRI of the spinal cord, the spinal canal space in here. This area, white area, is the spinal fluid. And these dark rings that are a little difficult to see here are cuts across the nerve roots. And the nerve roots, along their length, have nodules on them. Now, these nodules, initially when we saw these, we were very concerned, but as time's gone on, we've realized that they're not associated with any new symptoms, that they last for at least 6 to 9 months in the patients, and that they're more and more frequent with the higher dose of cells. And we've got 4 autopsies now with patients who died with these nodules that suggest very, very strongly that these are in fact MSC, nests of MSCs that have accumulated on the nerve roots and the linings, the meninges, but there's no sign of any malignant transformation. So first we thought this might be a bad sign, but this may actually be a good thing that the cells are surviving. So that's the study that we've been doing. The neurotrophically enhanced cells has been in collaboration with a company from Israel called Brainstem that we've been doing with colleagues in Boston at Mass General and at University of Massachusetts. These are bone marrow-derived cells treated in a way that makes them secrete more growth factors, at least before they're put into the patient. And the side effects, the adverse events, have been almost identical in the 2 studies. So this is the phase 2A study from with the bone marrow-derived cells. There's one other trial of stem cells in ALS going on, which is using human embryonic spinal cord-derived cells. And this is colleagues here in Atlanta, at Emory, and University of Michigan are carrying this out. And this is where the spinal cord-derived cells, embryonic cells, are being injected directly into the spinal cord. So this requires surgery, injecting the neurons into the spinal cord at 2 levels, at the cervical level in the neck and at the lumbar level in the legs. And again, the adverse events from this study have been very, very small. And this is much more kind of moving towards the approach that Dr. Snyder would say, where you're putting the neurons into the niche and seeing, will they do something in that niche that will influence the survival and recovery process? And one of the postdocs from the group at Emory has a poster here about this. So what are we looking at in the future? Well, we're in the planning phase for a 3-site, multi-center trial of the best dose of cells that we've seen in the phase 1 studies. What we're looking to in the future, though, is how other ways that we can modify the cells to make them more potent in terms of neuron survival. So we're using TALEN technology to have the cells overexpress a whole panel of neurotrophic factors that will be available for the future. Another thought is whether you can use the cells to deliver biological molecules of interest. Tau has become very interesting in the ALS and neurodegenerative disease world. It's beginning to be evidence around whether proteins like tau and other proteins that are abnormally folded can be and accumulate in the brain and spinal cord can actually cause cell-to-cell transmission in a kind of prion-like way in these diseases. And is there some way to interrupt this pathway by delivering something from outside? And then the cargoes that the MSCs deliver, there's a lot of interest in trying to identify, okay, if there is a response, what is it that's responsible for it that the MSCs are producing? So I'll stop there and just tell you that I've talked about leading the team, but it's a huge team, a lot of different individuals involved at all levels that have been exceptionally hardworking and trying to get this therapy into our patients. So I'll stop there and we can move on to the next section. And we'll be ready to take questions at the end.
I'm going to really just talk about the case study that I have been working at Buck Institute for research on aging. PowerPoint. No, I'll try to use this. So I'm going to talk about the iPS-derived dopaminergic neurons for cell replacement therapy for Parkinson's disease. I'm going to skip all the introduction here for cell replacement therapy. So the point I want to try to make is the proof of concept of cell therapy for Parkinson's disease has been done by using fetal-derived cell transplantation. So, but there are also, of course, a lot of issues which we think it could be resolved by using alternative cell source, such as pluripotent stem cell derived cells. This is the subject of what I'm going to discuss. So I'm just going to show you a strategy which we have been using to derive dopaminergic neurons or develop the whole process for IND-enabling studies. This has been done in my lab with a lot of collaborators. I'm just going to walk you through the point. So first, we should source or generate iPS lines that are suitable for clinic use and manufacture the cGMP-compliant dopaminergic neurons for transplantation, perform preclinical safety and efficacy studies, and obtain the IND for the phase 1 trial. So start with sourcing the cGMP iPS line. I'm not going to go to the details. These are just the key steps of the iPS manufacture, which we have done with Lonza, with the funding from the NIH. And a key step is to really just, to have the tissue acquisition, cell isolation, reprogramming, and expanding. And in our case, we use the cord blood cells and use the episomal vectors to make the cells. We have recently published the paper in Stem Cell Report, which we believe is the first completely cGMP-compliant iPS line made here in the US. Again, this work was commissioned by the NIH, and 2 clones will be made by the master cell bank by Lonza, will be made available to investigators. And we have also made a GMP reporter clones that will also make it available to investigators. And at this moment, we are we actually have just submitted a manuscript that we describe the whole genome sequencing data, SNP analyze, and other analyze that we will also make it available to all users. So in terms of manufacture, dopaminergic neurons for clinical use. So in the past years, we have developed a process. This is a scalable process which we can break down the process into different steps. Basically, you start with iPSC and then make neural stem cells and make dopamine precursor and then mature them in dopamine neurons. This is the last step, is more for in vitro or for potency assays. And the product here is actually we use a cryopreserved format. So this is the precursor cells, okay? Again, if you look at here, it takes about 14 days from neural stem cells to here. So I'm going to show you some of the data here. I just want to make a point, this is the product, and we have also used control cells at the earlier stage to look at the potency, whether the cells will make dopaminergic neurons. So I just want to point out this fact. So here is the process, and the process has been successfully transferred to a cGMP site, which we have made 3 dry runs under cGMP condition with 3 lots with different vials, lot size here. And using the cells, we have performed efficacy studies in a rodent model and tested the device. This is a surgical device in a large animal model, as well as using it for safety studies. So an example of the safety and preclinical safety and efficacy studies here. One is, this is the paper we have published with the manufacture process, and then the cells manufactured by the process. In the rodent models, in this case, we use the 6-hydroxydopamine model. Again, here is the cell groups. We have a control, and this is the point I said, it's just slightly before the product day, 4 days before, as additional control. And at the point when we do the study, we didn't really know whether, the cryopreserved cells will survive. So we have a control group that we use the fresh prepared cells. So these are the rotation tests, vitamin-induced rotation test. This is a control, and the other 4 days earlier cells and the product fresh prepared and cryopreserved. And as you can see, after 3 months, you see the significant improvement from the rats receive the products, regardless they are cryopreserved or freshly prepared. And the improvement persistent for 6 months. That's the end of our study. So the histologic analysis show clearly here. This is the control group. As I mentioned, it's only 4 days before the product. You see a lot of human cells survive in the graph, but you don't see them differentiate into dopaminergic neurons, whereas in the product, either is freshly prepared or cryopreserved, you see they differentiate into dopaminergic neurons. And this is just another way to label the human cells and the dopaminergic neurons. And we have also done some other histologic analysis of the midbrain markers, which I'm not going to go through all the data. So I want to show you also one data set that I have done with my collaborator and our clinician partner at UCSF, who has developed a device, and this is a radically branch development device that can be integrated with a FDA-approved stereotactic platform, which currently has been used for deep brain stimulation. So this device and platform can be monitored by real-time MRI, and this is look at the deployment. You can do it twice, and once and twice, and if you label the cell, you can see them. Now, using this platform that we have tested our cells. Again, these are the cells I just show you, the day 14 product, and in this case, we label the cells with GAP, and we have used the pig model. This is from our conversation with the FDA, we need to test the device in a large animal model. So our collaborator and UCSF decide to use the pig model, and this is just to look at the survival of the cells. Okay. And the data again has been published. This is the device we use and tested the cell. And I'm going to skip the data for here. This is the long-term tumorigenicity studies, which we have used ourselves, and this is done by a CRO. In the case, we use the Jackson Lab to do the tumorigenicity studies and other tox studies. So we had a pre-IND meeting with the FDA earlier this year, and basically we do receive positive comment from them. So here is where I am now. We have access to clinic-grade IPS lines and identify the manufacturer site and access to the drug master files, and have performed preclinical studies with cells manufactured by the cGMP compatible process. And we have coordinated with clinicians on surgical trial design, had pre-IND meetings, and at the moment we are seeking funding for manufacture of the cells for a phase 1 trial. So with that, I just want to acknowledge the collaborate from UCSF and various manufacturers. Thank you.
Okay, I have a session at 4, but we can take, why doesn't everybody come up, and we can have about 10 minutes. And then I have to go do my other session, but these guys can continue. So you can sit over here, I'll stand so that you don't have to. Are there any questions or comments for any of the speakers? Yeah, Dustin?
So, very nice talk. I have a question about the,
Talk real loud because we don't have mics down there.
safety profile of the there we go. So my question is about proliferating cells in your functional animals. You had, I think, 4 animals per group there, and you showed amphetamine-induced rotations. I wasn't really following it said percent rotations, but you had like 150 or something like that. So did you look at apomorphine-induced rotations? Did you look at the cylinder task? Did you have proliferating cells?
The proliferative cells, you mean. So for the histologic analysis, which we do not see any of the Ki67 positive cells, at least not in like outgrowths or any of them. So again, so if that's your question, so.
Yeah, and then what about other behavioral functional measures?
Other behavior function, for this study is just we use the vitamin-induced rotation test, but we also do the cylinder test, and those are not pharmacological induced test, it's more just like motor function test.
And are you seeing improvement?
We see the improvement,
Okay.
yes.
And then my last question is, what other cell types besides Th-positive dopaminergic neurons are in your graphs?
So if you look at them, the survival of the total cells is about 10% from what we've injected, and of them, about 20% are dopaminergic neurons. Other cells are pretty much just TUJ positive cells. And we do also see a bit of the still like nestin positive, look like stem cell, look like cells.
Well, that is how all the clinical trials are going. So in spinal cord injury, both Geron, which, in fact, all the clinical trials in spinal cord injury to date using cells have been in acute or subacute injury. In fact, the inclusion criteria need to be injury within 2 weeks. It's hard to know how to translate animal stuff to humans, but the feeling is a year's too long, probably half a year's too long, though we really don't know.
And does that make it difficult because there could be recovery over time?
Oh, that's exactly. Well, study design, even in preclinical work, is really very challenging because, in fact, there are a lot of really bad preclinical studies out there, not to mention bad clinical studies, because if you don't have somebody who really knows what they're doing with spinal cord injury, one, they can miss the spontaneous recovery that inevitably happens. If they make a lesion, even slightly spared fibers can then sprout and mislead you into thinking that what you did was responsible. And when you're dealing with patients, they're not experimental animals. There is variability, and the best you can do is project what you think is going on, which does mean, and this is exceedingly controversial, in clinical trials, do you have sham-treated, double-blind clinical studies? And there's a split, actually, between the European investigators and American investigators with regard to their view of that. It's particularly a problem in Parkinson's disease, where surprisingly, because you would never think that there should be this kind of a placebo effect, so to speak, there is. It's huge. In fact, you can lose statistical significance. In the clinical trials that have been done with fetal tissue, one study lost statistical significance and one barely made statistical significance by 1 or 2 patients. It's challenging, but Any other comments? So I do think you see, I think, I meant to, so what do you think is the mechanism? Have you looked at you've talked about what what you think the mechanism of action is in ALS. You didn't address what you think the mechanism of action is for Parkinson's disease. Why do you think the animals are getting better?
Yeah, I didn't really have time to explain a lot of things, so all we try to say right now is the studies, you can say, when you think about the fetal transplantation, which you are very aware of, and one of the things is that some patients are getting better, some actually didn't get anything. So I think it's one of the things is the batch of the cells, how you're going to standardize them. I think make an assumption that the cells develop into the right phenotype that provide the support that make the patients get better. So if you can standardize that.
I was actually thinking about in the animal studies you've already done, why do you think the animals are getting better?
Well, I think it's because they develop into dopamine neurons that provide
So you think this is new dopamine being produced by the donor cells, or do you think it's host dopaminergic cells being preserved, and they're the ones making the dopamine.
I think
And do you
it
see
is the-
connectivity? I mean, I know you have
Yeah,
to do all of
I
this.
know that connectivity is difficult to say,
Right.
but I think it's because of the dopamine neurons there. They are producing the dopamine in a regulate manner that directly provide a benefit.
Yeah. I guess the study would need to be, in animals, you can't do it in humans, would be do everything you're doing, but have those cells armed with like a suicide gene. So then you see good function, you see good dopamine, then you kill your cells, and that should disappear. Everything should disappear, right?
Yes, theoretically, yes.
So fortunately, the reviewers didn't make you do that, right? One last question. Do you think, in the days of the trophic factor work in ALS, not only did they not work, but some of the patients, particularly when they got NGF, actually experienced some pain because of hypertrophy of the Schwann cells around the pain fibers. Do you think that there's a risk in what you're observing with these MSCs around these nerve roots?
It's certainly something, as soon as we saw that, we were extremely concerned about that. So we were monitoring, from the moment we saw it, whether there was any signs of pain or anything related to that, and there wasn't. But I'd absolutely agree, because if you look back at the CNTF trial, for example, that was stopped because the cells were releasing so many cytokines in the nervous system that the patients got sicker. So,
Well, I got to run to do my next session, but you guys can continue.
Thank you.
And you can become the chair.
So any further questions? If not, we'll let you go and have a cup of tea. Thanks.